Thank you very much indeed. Fascinating outputs from a well-constructed network, and we will come back to discussing that. Can we have some questions from the floor? Yes, please. Just give me your name and who you would like to address the question to, please.
Yes, this is for Dr. Lamarca first. Actually, I have two questions. My name is Barbara Geratana, and even though I work for the European Commission, I'm here on a personal capacity as a caregiver for my husband. So I was curious, you know, the European Commission has now in place since January 2025 a new European Health Technical Assessment Regulation. So I was wondering, have you seen any effect of that new regulation in Spain to expedite access of patients to medicine?
No. At least my perception is
it for Angela?
Yes.
Yeah.
I don't think I have perceived any faster access to drugs. We are still waiting for Sanidatamab funding decision. But to be honest, I think sometimes the stops are not only at a European level, they are also at a Spanish level, because you have the approval by EMA, but then you need the approval by the Spanish government, which can take I don't know how long. And then once that is approved, all the hospitals have to assess that drug again and make a decision and include that in the local protocols. So usually if it is already approved by the government, your hospital cannot say no, but it's not always straightforward. If you ask me whether I have seen an improvement in the last year compared to 3 years ago, I will say I have not perceived that.
Okay, because I know the regulation was really put in place to address some of the regional differences within Europe. I'd be curious to know more about it and to try to figure out what is a bottleneck. I have colleagues at EMA working on it.
Thank you. Rachel?
Question for John and your experience in Konkan. I thought the observation of the intraductal tumour very interesting compared to the big desmoplastic, infiltrative, horrible cancers. So a question about biliary drainage. How are they doing biliary drainage? They have a preference. And also, are they doing fewer extended resections, and do they have good support in terms of IR embolization procedures? And
so, interestingly, drainage is not something we discussed in detail because, in fact, that patient was not drained because they weren't actually, and it reflects the lesion that's there. I mean, you could see why that patient may not be jaundiced because although it's got a little lump in the duct, the other side was unobstructed anyway. So I don't think there was we didn't discuss that. In terms of their radiology support, it's excellent. So they have got everything that we would want to have in terms of liver venous deprivation.
So the different pattern doesn't mean that they're doing fewer trisectionectomy?
So I think I don't know what you do. I have certainly gone on to just doing slightly more conservative resections because what you've got to do obviously is take the ducts. Taking more liver substance doesn't actually aid the oncological the oncological outcome of the procedure. So preservation, for instance, of the middle vein actually I think helps the patient in a post-operative setting in terms of restoration of liver function. So they are slightly non-that, and what I saw both in Konkan and Japan was a more conservative approach to rather than trisectionectomy. So there was a bit more liver preserved, and that's sort of what I've also been doing recently.
Okay, please.
Dr. Lim from Taiwan, not from Thailand. I have one question to ask Professor Lamarca and maybe other faculty. I want to ask how to establish and operate a cholangiocarcinoma focused MDT or collaborative groups. We know patients with hepatocellular carcinoma, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, or pancreatic cancer may be treated by different surgeons, different gastroenterologists, different medical oncologists. So, and some experts may be specialized in one kind of the cancer, and some may be capable to treat different, more than two kinds of this cancer. So, in facing such a complex team composition, do you experience some difficulty and how to resolve them?
So this is to developing specialist services, both surgically and from an oncology point of view for biliary tract cancers. Is that?
Yeah,
Good.
so how to make sure that within the oncology department there is one person leading on hepatobiliary and pancreas, right? That's the question. I think that comes down a lot to the person's interest. And this is something I learned from my time in Manchester. What I saw was a team of people fully specialized on one specific type of cancer. And we were only doing pancreas, biliary, HCC, and neuroendocrine tumors. And that's what I took back to Spain. But to be honest with you, with the exception of myself and Teresa Macarulla, we are the only two people in the country who do not see other GI malignancies. The reality is that you cannot always block your clinic to that type of practice. I don't think that's because of volume. I think there is enough volume in the big hospitals especially to have one unique clinic specialized fully and one or two people specialized fully on that type of cancer. I think it's a little bit of cultural. People are worried of doing only that. That's my concern. Huh? It's my feeling. Going back to Spain, what I have seen is people were asking me, are you only going to do this? And I was like, it's impossible for me to know everything of these 4 types of tumors. How am I going to do also colorectal, gastroesophageal? It's impossible. The volume is there. It has to come to a change in culture. And we have to explain to oncologists how important it is that in the department there is only 1 or 2 people doing that. But I think it starts by teaching those oncologists. In smaller hospitals, it's not possible. You cannot do that everywhere. But I will say you can do this in all big hospitals in Spain, and it's not happening in all of them.
John, do you want to comment on how we've achieved such subselective surgical procedures in the UK?
I think a key feature was the centralisation of pancreas cancer services, because liver tends to go along with that. I don't think liver has ever been, however, widely practiced. I'm sure you'd agree that it's unlike pancreas, which just about anybody seemed to be doing before there was centralisation. Liver tended not to be quite so widespread, and although there was the odd person doing the occasional liver, it wasn't that common. And I think, and actually since pancreatic cancer centralisation, I think HPV units have been established that it's very difficult. It would be very difficult to do, liver surgery outside of that.
So to come back to the point, so does that mean it has to be a top-down approach, and that you can't leave surgeons to make this decision?
So I don't want to be railroaded into saying something that you might quote me on at a later stage if, say, you had another agenda. Okay? But I mean, I think that pancreas was mandated. Liver was not, but in actual fact, it's achieved the same effect. So I don't think you necessarily need a top-down approach, although sometimes that's the only way of doing it. It was in esophagus, it was in pancreas.
Okay, does that answer your question?
Thank you for your answer. Thank you.
Thank you. Chad.
Yeah, thanks. So it's an observation I've had, and I wanted to ask John what he thinks. It's about the CASCAP program in Thailand. Most of us know about it, but just for those who don't, this was the concept in northeast Thailand where, as has been mentioned, liver flukes are the big driver and have made northeast Thailand the epicenter of cholangiocarcinoma in the world. 50 times the incidence of anywhere else, pretty much. And so in this program, as Wacharan mentioned, they go to the rural areas, they screen people, the stool for over and of the flukes, they give them praziquantel or whatever, and then they do an ultrasound, and then they send them to the teaching hospital to have a CT to look for early cholangiocarcinoma, and then the operations happen. Now, at the beginning of this program, the median survival for cholangiocarcinoma was 14 months, and they've published this data, and at the end of the program, the median survival post-resection tripled from 14 months to 40 months, and hardly anyone knows that. I gave a talk at ILCA in October in Hong Kong on surveillance, and no one knew this, and I bet most people in the room don't even know this. Why is that not celebrated? If anyone else had come up with an intervention that triples survival time, how comes this is not being shouted out from the rooftops? Is it just because it's so localized? Is that the reason?
So what I would say is that there is in that bit of Thailand, there's low-hanging fruit. So you've got a situation where high incidence of the disease, and it's not, patients haven't actually had access to treatment. And you start a program, you're starting to pick them up at an early stage, and lo, you get the result that you've highlighted. But we couldn't do that because it's a low incidence disease here. Yeah. So I'm sure it should be celebrated more, absolutely. Yeah. But it is a function. It's a function of the environment. It's an area in which it's been possible to do that. Now, that's not minimising the endeavour and the enthusiasm that's led to that. I mean, that has to be congratulated. But there was actually the opportunity to do it, and it's an opportunity that, frankly, we don't have, at least at the moment. I mean, it may be the blood tests for cancer, which are being trialled, might begin to pick up early stage bile duct cancer, but I'm not sure.
And John, you said 3 cases out of how many people were screened in that afternoon or whatever?
A few thousand.
A few thousand.
Yeah.
A few thousand in one afternoon.
Sorry?
A few thousand were screened in one day. Few thousand, 2,000.
Yeah.
Wow.
Can I have a question for Rohil? So I've spent a lot of time on UK funding panels, and I look at your Ability to Track network and think that's a fantastic achievement. And I presume this was through Horizon funding, was it? The network was produced and funded?
You mean the funding for the cost action? I think
for the network.
Or the network? I think it's a little independent, but it's a European funding. Yeah. So
one of the issues that we always struggle with is that if you put a network together of experts, you produce huge volume of very good work. And then you have to prove that producing the network and the funding for the network achieved more than you would just get from that number of specialists. Can you comment on that? And can you comment on how you're going to be expected to take the network forward? Are you going to use the evidence of outcomes to get more money to continue the network? Or was the intention that the funds would produce collaborations that would then self-support the network?
Okay, I think the cost, they think that putting people together will produce more advances in all the topics. In fact, they fund all type of topics, from bees to forest to any topic, music, any topic you can think about. They have projects, they have funded to create these networks to work together, and they have like as a premise that they are going to have more results if people are together. In fact, what they found is only the possibility to have these activities to put people together. So it's like I don't have to demonstrate because they believe in that, and that's why they found these networks. Of course, one of the things that for us is important is to continue the network because we see that we do more things together. In fact, previously we had a previous cost action that was Eurocolagnonet, was coordinated by Vincenzo Cardinali, and when we were finishing the network, the project, we thought that we could apply for a new cost action to continue the work. But here you have to do it well because they don't want to fund again the same network. So we switched the presentation and we made a proposal about precision BTC, including all types of cholangiocarcinoma and precision medicine, something different. And again, what can we do after 1 year and a half? When we plan to apply for 1 extra year that you can do when you are selected after, in a few months they will tell us if we can apply for the extra year, and if we can do it, we will have the possibility to apply and have 1 more year after we finish, but we don't know if we are going to have that. And we want to apply for another cost action maybe, but also because we have this network, we are applying for European projects. It's true that then you have like funds for research, not just for the coordination and being together. So we will have to think about other possibilities, maybe with pharmas or with our funds, or what can we do?
I think there is something to notice about the network. So that is all of us coming together. And once you know the people, then other things come up. There will be things that happen anyway. For example, Julien's project on the adjuvant study and those 5 million, congratulations, is something that will have happened regardless of cost. But there are other projects that need cost and the funding for us to come together to become a reality. And for example, the 3 papers we are working on the centralization of care, that's something that if we were not together in the same room, in that training school, that would have never been done. So I think there are different types of things where you benefit more or less from cost. Julia.
Yeah, just a testimony and to discuss about, for sure, the trial might have been done without cost, and we have bring together the SAFER AB10 with John, Juan, David, without cost, but it's facilitated and it creates occasion. And in fact, SAFER Impact for real, and I'm not sure I've discussed that with you or so, the idea we thought about this within the SAFER ABC10 management group, but the first occasion that I discussed that with Angela, Lorenza, and others was at Warsaw Cost Action meeting. So it's an occasion to discuss and see whether we are all agree on the concept and work together. And yes, it creates occasion and it's improved collaboration.
Lovely, thank you.
Thank you.
Can I maybe finish with a question for Angela? So you're in quite a unique position of working in both the UK and Spain. And this whole meeting is about improving our outcomes in cancer, biliary tract cancer, focused obviously in the UK. What would you suggest that we do in the UK to improve our outcomes?
I think you have to improve the diagnosis process. There is where you are behind. In that time, from the beginning of the symptoms, requesting an appointment to the GP, the first appointment with the GP, until the first CT scan being reported, the biopsy, failed biopsy, repeat biopsy, up and down, 3 weeks from one appointment to another. That is the reality in the UK, and there is where you are behind.
And what's that due to? You know, is it shortage of equipment or is it shortage of
I don't know, because
will?
the reality I knew was Manchester. So Manchester, there was one cancer center, but then other smaller hospitals, and sometimes, well, not smaller, but not cancer center. And the patient had to go sometimes from one center to another for the ERCP, and they had to travel, or there was a long delay between the CT scan being done, reported, then taken to the MDT. Now we need an ERCP, then the ERCP is requested, and there were delays. We actually did an audit on this, and we saw a huge delay in that process, around 3 months or so. It was something, yeah.
Okay, so we're going to have some further comments. If there are any patients or carers in the audience as well, I'd be very keen for them to comment on this as well. What can be done to improve the infrastructure in the UK? Trish?
I was just going to come back. I actually trained in Manchester and saw those problems, and now I work in Wales, and I see those problems that I feel are even more amplified because of the geography of the country I work in. We have a huge problem with radiology. We have not got enough radiologists in the country. Radiology reporting is very slow. And that is a problem that has been seen nationwide, and there is a problem recruiting radiologists as well in the UK, and obviously good radiologists, particularly HPB radiologists for diagnosis and things, getting those reports out quickly is massively important. But we have a problem fundamentally with our hub and spoke model, and I think you commented earlier, why did she have to wait in the local hospital for scans and things being reported and not get pulled in? And I don't think us as cancer centres or HPB centres necessarily have the capacity to import all that extra radiology and everything in. So that's something that
yes,
needs
so
to be
Trish, how are we going to do that? Because, who's going to train radiology with AI coming in? Nobody's going to do it. So how do you get and maintain world-class radiologists?
You know that not all radiology, we have cholangiocarcinoma that's misdiagnosed as, giant hemangiomas and things all the time that get then picked up when they represent. So not all radiology is the same. Is AI going to be so good that it's going to eliminate all of that? I don't know. It's the honest answer.
Johan?
So I think there's also been a little bit of a reluctance to step back, think big, really make a change. So one of my suggestions that went absolutely nowhere, but I still think is a good suggestion, so I'm going to tell you now. We're wedded to this idea of a weekly MDT. You spend 4 hours in a weekly MDT. Why don't you have a daily MDT? And I know, but you're not committed.
Saying this for years.
Okay, I've said this for years. But you just have a 1 hour MDT. You have something that's algorithm driven. If somebody has multiple metastases, never going to get to surgery, you can put through an algorithm. They need a biopsy, straight to oncology. You don't need to have a big, long discussion about it if it's something as simple as that. You save your MDT for hot cases, make a quick decision, and focus on the patients who need to have surgery.
Angela, do you want to comment on that? Because you were actually commented on the lack of MDTs in Spain, as if that was something that we had to correct.
There are MDTs, but they are not as well established as here. There is the rule of you need to send the patient before so they can review the case. All this is very good. This works really well in this country. You have to refer the patient at least 1 day before to review the case, then there is a list, everyone has the outcome, then the outcome goes, then there is a registry of the fact that the patient has been discussed. All that is perfect. You have 2 screens. All this that you think is normal is not normal outside this country, and that is absolutely fantastic. So you have to keep the MDT. But this weekly MDT that Juan says, that has been saying this for years, I find it very difficult because you cannot replicate all that every day. So you could maybe have a smaller MDT, but my concern there is that you are going to go to what I have. And it may not be great, because then maybe the multiple liver metastases are not liver metastases. And maybe you miss part of the super expertise if you do that. But I'm not saying you are wrong.
No, but I think from a patient's point of view, to say, we're going to have to wait 7 days or 6 days because you just missed it for the next discussion, before they say, you need another test, and then you have to go back to the MDT. We're just building.
This is a difference. In Spain, things happen while you are waiting. So there has to be a balance, because it's true that sometimes a patient comes to the MDT and they have put a metal stent and the surgeon is really saying this should have not happened. but maybe the biopsy can go ahead. You don't need to wait 1 week to do a liver biopsy. So I will say that there needs to be a balance. The difference is in Spain, things happen while you wait to the MDT, and when we go to the MDT, maybe 10 days from the first scan, you already have everything, but the big decision about extending could wait. We are actually working as part of this national Comité Nacional. Some endoscopists came up saying, we don't know when to bring the patient to the MDT, or we don't know when to stent and not to stent. So we are working on an algorithm for Spain of how to follow the diagnostic process, when do you have to stop and go to the MDT because of this metal stenting, for example. So I think there has to be a balance between UK system, I don't do anything until the MDT, and 2 weeks may go because there is a bank holiday, or do something in between.
Do something in between. John?
So, Juan, we normally agree. Okay, we normally agree. But that's just a crazy, crazy idea. Now, I think the MDT is a hugely expensive room. It's the most expensive room in the hospital, and we don't use it particularly well. It should not be used for micromanaging patients. We're all experienced clinicians. What you need to do is get some basic stuff done on the MDT, and then just get on with it. What we do, just in terms of Hilers, if we sniff a Hiler anywhere in the region, we just admit them. Just bring them in and do them. And then you get all the radiology, you get the drainage, all in a short time. So we don't let I shouldn't maybe say this, we don't let the peripheral centres do anything. We just admit them.
Okay, maybe last 2 comments or 2 quick questions.
So, Angela, I totally agree. I think the problem here in this country is the delay in diagnosis. Absolutely, right? And Brian asked why. I'll tell you why. And I'm speaking with my generalist hat. I do a specialist HPB cancer clinic, but I also do general gastrohepatology. I do general endoscopy, and I did acute general medicine for 15 years as a consultant. The problem is, it's the model that we have of primary care, because primary care doctors, essentially, whether people want to say this or not, their role is to stop people coming to hospital. And they are actually charged with that. Don't get people to hospital, particularly when the funding model means that the more referrals they get penalised. GPs, in some areas, depending on the contract, will actually have their referral to a specialist gets bounced by a panel who've never even met the patient, right? So when you have that model, then how is the person actually going to get to secondary care when the model is to prevent people getting to secondary care? I think that's a key driver in all of this, personally.
Yeah, I agree. That's a problem.
Okay, you've agreed.
Here.
Last comment for the session.
Sorry, just to follow up on the MDT question. So I can certainly attest to ballooning MDTs. I've been MDT lead at Cambridge for the East of England HPB MDT for the last 5 years. Our numbers have increased despite trying to implement protocols to reduce it. And I think there's 2 main drivers here. I think the first one is as we become more specialised in the hub areas, the regional hospitals get less specialised. So patients get referred to the MDT as much as anything for discussion of radiology, because their local clinicians are not always convinced that their radiology report, which is often outsourced to sometimes a different country, might pick something up. And the second thing is become quite a lot of a governance issue as well. And certainly there's some aspects of that can be moved out of the MDT, but it's become a governance issue from referral from other referrers, because there isn't job planning time for their local MDT leads to triage it appropriately. So there's a lot of layers of problems, I think, with the MDTs. I don't love the idea of a daily MDT, just to point that out.
Okay, thank you very much for that comment.
Thank
I think
you.
we have to wind up the session. Angela is going to close the session.